drugs, they made a dramatic difference in the survival rate, whereas over 80%, mostly through very well-designed, controlled clinical trials. And a big difference is really what Dr. Stewart said, is that in a disease like pediatric leukemia, all the children go to specialist centers to receive treatment, where they're all enrolled in clinical trials, and over 90% of children go on clinical trials. And that we need to encourage that and explain to patients why that's important.
Yes, Mary.
I was just thinking of it from a patient perspective, and I think everybody's hit on a couple of things, that there's private practice versus academia. If you're a private practice, you're not going to hire a clinical research coordinator to do one study that may only, enroll 10, 15 people over the course of a year. And if you're asking somebody to go to an academic center, if I live in South Phoenix and the trial happens to be in Mayo, at Mayo, it's going to be at least an hour drive for me. And if I've got to go to get fasting blood and whatever, that's a barrier for me as a patient, even though, I may know intellectually that, it's important. And, they may not, follow-up appointments might be once a month. I might have to go attend in the morning one time, 2 in the afternoon. I might have to ask my employer, I need time off. I've got to drive there for an hour. I've got to be there for an hour, and I'm going to be doing this on a monthly basis. So I think that there are things that we need to look at from a patient perspective as well, because the patients are what's going to drive the clinical trials, and I think you have to look at it from that perspective and try and remove those barriers.
Yeah, I think we hit on one. Some patients will self-select and be very interested in a trial. I think there's resistance from other patients. Dr. Kyle mentioned that, patients diagnosed with myeloma, they're told it's a treatable but an incurable disease. And then if you add on top of that, we want to experiment on you, they don't understand what a trial is. They hear that. So there's psychological barriers, I think, for patients as well. To admit that you're in a trial, I think maybe then says, okay, this is a more serious disease than I would like to deny that it really is. So there's some psychological barriers maybe for the patients to have as well. Yes, Jack.
Yeah, I agree with that. People, when you think of
you have to speak up.
sorry, when you think of clinical trials, I think people think, well, it's the last resort. But the question I have on clinical trials is sometimes you read about some of the people get the medicine, the stuff they're testing, and others are just getting placebos. And is that always true in a clinical trial, or only partly true?
From my, Dr. Kyle mentioned, for myeloma, and I would stress this importantly, the best trials, really trials, should be the state-of-the-art best therapy you can get for myeloma, plus or minus an additional new drug. No one gets a placebo anymore for something like myeloma, because there are other therapies for it, so it would be impractical. But people think just like that you're going to either be untreated or treated, and that's a barrier that we have to try to get out to the public. I would think for somebody without insurance, that if you got into a clinical trial, would that allow you then to get at least the state-of-the-art therapy for a person with no insurance? Could they then get into a clinical trial and get at least the standard best therapy?
There are trials where you get drug provided for free, so that in certain instances clearly an advantage, but certainly at Mayo there's probably not true other hospitals. Getting in the first place is where the insurance causes the problem. But certainly for some patients there is an advantage financially as well as treatment-wise.
So yeah, if we make the point that people who they've got studies in just being in a trial, even if you don't get the test therapy, people live longer because they get intense therapy. They get people doting over them. They get better monitoring. There's an advantage just being in a trial whether you get the experimental drug or not, just because you're getting that higher standard.
I'm going to comment on that because right now there's Dr. Bergsagel was here, 3 Mayo doctors that I know of. The patients who are seeing them, who are in clinical trials, are clearly alive because they are in the clinical trials. And there's not a question in my mind. I get emails back from them, many of them because, I've been out there saying, you've got to try Mayo again, because most people don't know. And that's really one of the biggest barriers. It's not a question that they're resistant or they're afraid. They just don't even know that that's a possibility. It wasn't just me who, initiated it, but some of them came to me and were fortunate enough, and then when they heard about it, they knew that that was an opportunity. And some of you will be here tomorrow, will see some of those very patients who will say, thank heavens there was a trial. But, again, as Jesse said, with all the, lack of information, it just seems like so daunting that no matter, what we seem to be trying as researchers, we really have to do more from the patient side to really, or what I call the community side.
Barbara, there is a website, clinicaltrials.gov, but I think it's in English. I don't know if they have the Spanish version of it as well. So, I mean, there are sites, there are resources for patients to do all that, but, if you don't speak English, I'm not sure if that's
Right, and just so you know, my name is Victor from the Leukemia Lymphoma site. No, but I do want to hit on something specifically to language, and I know we're kind of getting ahead of ourselves, but for example, there are organizations that do take clinical trials very seriously, and I don't want to just put a plug in for my own organization, but we do offer that specific service where we do match up individuals that can be potentially in a clinical trial through our national 800 number, and we do provide those those services where the patient, if language is a barrier to just learn about a clinical trial, we provide that in terms of a translator or somebody that speaks the same language. So we try to provide that. Now, locally, can we do the same thing? Obviously, we don't have the resources here locally, but I think through organizations like ours that are already providing those things, those are certainly resources that are available to the community, especially we're starting to look into populations of color.
Yeah, and that's very important. And one of the comments that Victor just made is that a lot of people don't realize about the resources either, which becomes another piece. Multiple Myeloma Research Foundation has on their website an opportunity for people to look at that. But again, we're finding people call us up just because they Google, myeloma. And fortunately, we're now including that on our website and so on. So all these linkages are really, really important. And that's why we always invite resources. And there will be Arizona Cancer Center with a display tomorrow. LLS will be here. We try to bring as many resources here so people can get that information. So it's a real challenge for sure.
Barbara, one more question.
I do know. Yeah, Jim Marday here. And follow-on question to a comment that Jack made. He made a statement that clinical trials are often seen as the last resort. I've never really thought about that. I've never been a cancer patient myself, but I'm curious at what stage after diagnosis are patients typically admitted to a clinical trial? How many other procedures may have they gone through by the time they even think about a clinical trial or are admitted to one?
We have trials open for all stages of disease. We have trials open for newly diagnosed patients right now, which I think are some of our better trials, to tell you the truth. But Jack is correct. The community oncologists tend to think of trials when the standard therapies have failed. So the most common referral we get is somebody who's been through 3 or 4 treatments, and the community guy is running out of options, sends off to see what we have that's new. But we'd actually rather see them earlier.
That's what I would think. Like if I were a patient just diagnosed, I would want to seek out to educate myself what trials are available earlier than later.
Yeah, and I just want to echo what Dr. Stewart was saying. We get a lot of patients when they are desperate to find additional resources.